Το δεύτερο μέρος της παρουσίασης είναι ο κύριος Scott Corney, ο επιχειρησιακός διευθυντής της Avellino. Scott, you're my guest.
Thank you, Christo, and I want to thank everybody. It's a great honor for Avellino to be here, to visit Greece and to introduce our company and our test to you, and to thank you all for a beautiful Greek Saturday evening that you're here with us rather than doing much more enjoyable things, but we really do appreciate you coming and meeting with us. This portion of the presentation, I will expand a little bit on the clinical aspects, but I really want to give you a little bit more information about our company and about how the test really works. So as Sandra had indicated, our company has actually evolved and continues to evolve very rapidly. As when Gene founded the company just a few years ago, it was all about this one test, this one inherited corneal dystrophy that was called GCD, granular corneal dystrophy type 2, or sometimes referred to as Avellino corneal dystrophy. And this 2 years ago, we expanded the test to two types of corneal dystrophies, and then last year to 5 corneal dystrophies. We are very much as a company on the move. We are committed to expanding our test to the ophthalmic industry to find beneficial tools that you can use to help diagnose conditions, and even more important, that we can provide you tools which are actionable so that you're able to use it. So in this case, we've prepared a 5-test system that is addressing the most common types of dystrophy from literature for TGF-beta induced gene corneal dystrophy specifically, because these are the conditions that are exacerbated by trauma to the eye. So these are the conditions that on the next slide I'm going to show you is these are the things that we're looking at today in the industry that can exacerbate the conditions seriously. So somebody was asking me at the break about why the difference in people. And one of the analogies is a case that we recently did. A patient came a doctor sent a patient to us for testing, and this patient actually spends his summers as a river raft guide on the Colorado River. So he's seeing a lot of refractive light coming at his eyes all day long, which is creating an injury to the cells in his cornea. And so as a result, his corneal dystrophy is seriously advanced, and to the point where he's 28 years old and he can no longer drive. Whereas when we looked at his genetics, his condition is inherited on his mother's side of the family. We looked at his mother, and his mother has a clear phenotype. But she lives an indoor life, and she hasn't done anything to exacerbate her condition. So this is the best analogy I can provide to you as when we create a trauma to the eye, these are the conditions that are contraindications to corneal dystrophies that we're testing for. So the ones on the top of the list are very well known: LASIK, LASIK. When we started our company, the only contraindication that was known was in LASIK. And as information is learned, we're continuing to find that all these common refractive procedures are represented as contraindications. I can tell you that we put on this list cross-linking. Not yet. We have not found a case, but cross-linking is very new. But there's all evidence to show that the trauma to the eye, 2 to 5 years post any kind of trauma to the eye, will start to show cases. And we've actually met with a doctor yesterday who said to us that they believe that they actually have a case, and we're going to be doing some testing on that. But in general, as we talked about earlier, it could be the corneal transplant. When we put down here premium cataract, what we're referring to in the United States are the premium IOLs where they're going to put, afterwards the surgeon is going to have to do an enhancement, a LASIK enhancement. So prior to the cataract, many doctors are starting to recognize that they can test the patient first when they come back and have to do a refractive enhancement, that the patient has already been tested and cleared for procedure. So these are the types of indications. If I go back to the previous slide just for a moment, this is one buccal swab. This is the whole test system. It's very rapid. Our company actually has 5 patents around this technology where we've actually been able to reduce it to the point where we can give very accurate data to the doctor, 100% sensitivity and specificity, which I'll talk to you about in a moment, and be able to provide this very quickly, within hours. So when the sample arrives in our laboratory for analysis, within hours, we are now able to report back to the doctor the results on that patient. That's our proprietary technology. That's what we've been able to accomplish, and we've been able to do it at a very affordable cost as well, and that's the key to making it useful as a tool for the refractive doctors. So here's a perspective that's very meaningful in its totality. Gene founded the company in 2008 in Korea. I'll share with you that when he went to the first refractive practices in Korea, they all said without exception, we've never seen this before. It's not a condition that we really believe that we can miss with, that we can't, slit lamp examination is enough for us. And so then we got a few bold doctors to use the test, and within a very short time, that data that Sandy showed you earlier as 1 per 870 started to show itself. And we started to find many, many cases in the Korean population. So we started by having a clinic, a laboratory testing center in the 2 towns of Busan and Seoul. In 2010, we decided to expand the test to the neighboring country, Japan. And in Japan, the same experience. But even more intriguing, the doctors said to us, this is a Korean problem, we don't have it in Japan. And so in that case, we convinced them to try the test. And again, we were able to find many, many cases through testing to the point where today, having done 500,000 tests, primarily in those 2 regions of the world, we've been able to show it to consistently at maybe just below 1 per 1,000 in those 2 countries. In those 2 countries, the test became a standard of care. Over 80% of all refractive candidates for LASIK or any of the other refractive procedures is now being tested for the DNA condition for corneal dystrophy. In fact, when in the United States we get people who are living in Japan or Korea, who are doing work in the United States, come to us and say, where do I get your test? Because we know that that's expected safety evaluation for the criteria of refractive procedures. So this is about the time that Gene hired me in 2012, and he asked the question, well, what's going on in the rest of the world now that we know a lot about Korea? And so we knew that if you look at the very bottom, it says known prevalence. So that's referring to Korea and Japan. But what about the rest of the world? What about Greece? What about the United States? What about other parts of the world? And the simple answer is we don't know. But what we do know is that when we survey literature and we look at the cases in published peer-reviewed journals, that we find that there are many cases. And to the point in which it's hard to find more cases in the United States, because now that we're finding many more cases, we go to those doctors and we say, publish it. And they say, well, what's new? What's special about this? We already have enough cases documented. But look at the United States. In that table that I have there, if you double click, when we double click on the number 8 is for GC1, the number 21 is for GC2. You see that there are cases in the United States from representative of the world. The top one is Africa. Because as you know, nobody in the United States is from the United States, right? Unless they're Native American Indians. So we see North and South Americans, we see Eastern and Western Europeans, we see Asians. People are represented from all over the world with documented cases in the United States. By the way, I think Native American Indians also are pretty good carriers of this condition because they've traveled across that continental divide, that bridge to get from Asia over to North America. So that's another interesting thing. Another interesting thing is that you don't see very many cases here from Africa or from South Latin America, but that's not because they don't exist. It's because we're doing peer review journal surveys, and there's not that much academic work being done in those parts of the world, so there's not that much being published, and because they're mostly developing or underdeveloped countries, there's not that much refractive knowledge coming to us. But our belief, based on talking to epidemiologists, is that perhaps the greatest concentration is actually in Africa. So that one African American is not a big surprise to us, because when you have a condition that's global, that's across all ethnic groups around the world, you know it's an old mutation. And since we all derived from that part of Africa and the Middle East, probably when we get enough the ability to do studies, we're going to find the highest concentration of corneal dystrophies in that part of the world. So look again now throughout Europe. We have 49 cases now of GCD1 and 30 cases of GCD2. So we don't know for sure. So our company is actually rewriting the textbooks every day. And we actually believe that when we read an article that's 5, 10 years old and it says GCD1, GCD2, they probably don't even know the difference. And so unless they go back and they do genetic testing, we've had cases brought to us and the doctor says, I have a GCD2 case, and we test them and it's a GCD1. It's not that important. It's the same issue either way, but from a academic expression perspective, it's very important for us to know and understand how these conditions manifest themselves. You look along the Pacific Rim, starting at China, it's a very interesting story. You see that China has 23 cases of GCD1 and 20 cases published of GCD2. I'll just go to the next slide. Our company just launched a genetic test in China, a laboratory in Shanghai. And in the short period that we've been doing testing in China, we have found every type of the 5 corneal dystrophies expressed GCD2 at about 40% of the population. And we've now collected about 80 plus cases in a very short time, 92 cases in China, to the degree in which the doctors are basically telling us that they've seen too many cases, they've created too many cases, the test has to be available to them. So it's catching on very rapidly. Let me go back. Whoops, back. The one thing I wanted to mention is this. This is called CLIA certification. So what's really unique about the lab in the United States is that we've achieved a standard of excellence comparable to the what the FDA does to medical devices and drug therapy, is called CLIA. It's also a governmental regulated program for diagnostic testing. And our laboratory has passed those standards of excellence to the level in which we can now support clinical trials and meet the standards required pretty much throughout the world in our laboratory in the United States. So at this time, tests that come from Europe, from Greece, will go by overnight delivery courier to our laboratory in Menlo Park, California. I would expect within a short period of time, we'll be putting a laboratory in Europe, location to be determined, but bring it a little bit closer so that we can cut the transport time of the samples from 2 to 3 days to 1 to 2 days and give you more real-time information. Because again, understand, the limitation is not in the test. The test can be done in a couple of hours. Our biggest limitation right now is the transportation. So we're looking at fast ways to address that as our biggest obstacle at this time. So we're very excited about the lab in China, and we'll be expanding our business very quickly in the largest refractive market in the world. We've also, just to give you an example, is my colleagues and I have been traveling a lot in the last year and a half, to the degree in which we now have developed relationships as with Optohelis in in Greece, we've developed similar relationships in over 50 countries around the world. So our test is rapidly gaining momentum and interest to be able to provide this in all parts of the world. And this map is almost incomplete based on the activity that we're involved in right now to continue to expand the test. So I talked a little bit about CLIA. CLIA is also complemented by what we've accomplished in clinical trials. Our company, over the last couple years, has actually executed 2 clinical trials. The first one for GCD2, Avellino, and then most recently for the 5 test, for the 5 corneal dystrophies. And in those studies, we're using double-blind studies with controls and then positives. We've been able to achieve 100% sensitivity and 100% specificity. So that's an amazing accomplishment, and that's something that we can't guarantee the next test is going to be that accurate, but because we have developed a technology around a single point mutation, we've been able to get it to be that accurate, where we have the doctor can be confident when they do a test, they're going to be telling the patient that there are no false negatives, or the risk of false positives, for that matter, are minimal. When we give you a result, it's yes or no. We're going to be able to tell you whether you're a good candidate for refractive procedures for going forward, or if you're at risk and we need to find other alternatives. So let me explain to you the test process itself. I love the words simple, fast, accurate, affordable. I mean, how much better does it get than that? So it is that simple. The entire test is what I'm holding in my hand. It's a buccal swab. It's CE. It has a CE mark on it. It actually is manufactured in Italy. And this is the swab that we've chosen for our test. This is the protective tube. The actual buccal swab is inside the tube. It has a sterile seal on the outside, which once it's twisted and broken, you can see the sterility has been compromised. The swab itself has no chemicals, no preservatives. It's what it is. And so the procedure for sampling the patient is very simple. I'm going to demonstrate. 10 swipes on the inside of the cheek, rotating it and pushing firmly on the left side, and then repeat it on the right side, and then you return it to the tube. That's the system. In some clinics, most clinics, the clinician or the counselor will do it to the patient. In some cultures, the patient says, "You're not putting anything in my mouth. I'm going to do it to myself like I did," and that's fine as well. And that collects enough buccal cells from the inside of the cheek to give us enough DNA for analysis. It's really robust. We've done tests after alcohol, after chocolate, after gum, after food, and although our clinicians hate when they see food and gum and chocolate on the swab, we just normally say, if you've done it, rinse your mouth with water first, and then let's take the sample. But the only thing that's really imperative to emphasize is that we don't get samples from the tongue, because the tongue harbors a lot of bacteria, and beyond that, it's very robust. It's easy to sample, and I can't remember if the next slide has it. Here it is, and it's stable. So if it's stored at room temperature, 13 days stable. So that's from the time of sampling to the time it arrives in our laboratory for analysis. If it's stored at room temperature, it's good, it's valid for 13 days. However, it's really simple in the clinic when they put it in the refrigerator, and then it extends it to 1 month, 4 weeks. And then if you put it in your freezer, it's beyond 1 year. So again, if maybe a clinic is waiting to find out whether the patient is committed to the LASIK procedure, they don't know, and they don't want to send it out for analysis until they know, just pop it into your freezer, and then on our requisition form, you just check the box saying how it was stored. And it's that easy, it's that stable. This is the second part of the system. It's called a test requisition form, because our test to date must be ordered by a physician. So the form itself must be completed in full. It must have the name of the clinic that's asking for the test, a signature by the ordering physician, the name of the patient, and on the bottom left you'll see a rectangle. That's actually a label. The label, as you can see, it has a barcode that's the same as the barcode on the top left of the form. So when that gets peeled off with the patient's name, it gets adhered to the swab, then we know that this swab goes with that patient. And when it arrives in our lab for testing, there's no questions, there's no confusion about who this belongs to. Next part is even easier. You take your collection of swabs collected for that week or for that period, you put it into an envelope, a plastic zip top envelope that we provide, and we provide prepaid courier delivery to our laboratory. So in that case, we get this sample shipped out by express. It's either UPS or Federal Express, depending upon the country and the cost. But we go with the fastest delivery system that we can work with, and then it's shipped out and we receive it within a day or two. Once the test is completed in our lab, the next step is we notify the clinic. So on the left is an email. The email goes to anyone in the clinic that wants to know. So we send an email and we say, the test is now available on the password-protected web portal. That's on the right. The password-protected web portal we assign to the ordering physician or physicians, and then they have access to the report easily when the result is done. And then in that web portal is the actual report. In this case, you can see the 5 mutations that are being studied. The top one in this example is heterozygous positive. The other 4 is normal. Most of the time, all 5 are listed as normal. When we do get a positive, it's not enough for us just to put that into the web portal. Our protocols require that we find a way to make sure that the doctor is notified so that there's no risk of missing it with the patient. Just as an example to you, our company has learned from experience that, and we respect that the clinics that are adopting our test are changing their protocols. They have to incorporate our test somewhere into their practices. So we've made a number of measures to make it as easy as possible for those clinics, to the degree in which we've put together a training session that is pretty much systematic for helping the clinicians know how to introduce it into their clinic and how to swab, how to get replacement supplies, and how to talk to the patient as well. And so in this web portal, it's accessible through our website. It's also directly accessible. Optohelis will explain to you how to access it. They may even translate it into Greek if that's something that's preferable for you. But in there, we have all the training supplies, even marketing supplies, even example press releases for what you want to say to the media. Fill in the blank, put in the doctor name and the clinic name, and away you go. So we've created as many tools and resources to make it easy for the clinics to be able to introduce their patients, their advancement in the newest technology available. And that's something I want to say again to you, is when we train the clinicians, we normally will give them a little brief education about what is corneal dystrophy, but then we tell them, when you talk to the patient, you don't have to explain corneal dystrophy to the patient. What you explain to the patient is safety. We are introducing the newest use of technology to give you the best outcome possible. And that's about your safety. It's about the patient's safety. It's about the doctor's safety. It's about protecting the industry at large. And we're just taking something that's really good, really effective, and we've eliminated that much more risk to make it that much more safe. And that's what our test really does for the industry and for the patients as well. The patients love it. They want to know, for an elective procedure, how can I get the best outcome possible? This is an example of some of the marketing tools that we provide. Even at the bottom, you can see you can plug in the name of the clinic and away you go. Patient brochures, videos, all kinds of educational media and materials that people in the clinics will benefit from. Typically, the clinics will receive the supplies in a supply box. This is, provides 10 patient tests equivalent, so 10 swabs, 10 requisition forms, the shipping materials, and instructions for how to use the test. And this is really, when it comes down to everything else, you've heard about prevalence, you've heard about our company. This is why Gene founded the company. This is why we're proud to be part of standing before you today, is that we've protected 582 people, and this was updated, as you can, whoops, that's a outdated slide by about a week, but every couple of days we update on our website the numbers. And we've protected over 582 people from the risk of advancing their condition. So the majority of these people are through pre-LASIK, pre-refractive screenings in which they've manifested themselves. They've presented themselves in a way that most likely the doctors would have missed and would have proceeded with the types of cases that Sandra showed you, where it's a mild phenotype, it's confused for something else. Those cases that we present to you would not be available if it wasn't for the fact that doctors are misdiagnosing the condition. Gene opened our session, so I'll close our session by telling you how important it is that our technology is changing the world. We were recognized by the World Economic Forum for just that. It's not only about what we've done to date, but they judge people based on where they're going in the future. And our company is making major progress towards finding other conditions that are important to the ophthalmic industry, that's going to be useful in a predictive and a preventive way to help us find the best tools for treating our patients, and going forward someday into the ability to be able to treat them as well. So this is what our company is about. We're very proud of that recognition, and I'll just close again by saying this is a tool that's used in many other parts of medical industry, routinely for cancer screening, for heart conditions. It's being for rare and exotic diseases. So why not? It's time that the ophthalmic industry recognizes that there are tools available that they should be making the best use of. Around the Hippocratic Oath, do no harm. We want to make sure that we do no harm to our patients. So thank you very much for having us this evening. Thank you. We now have microphones at the table as well, so any one of us are glad to take any questions that you might have. Did we cover everything? Yes. Oh.
You said that the real
Hello, I'm Dr. Osbaraka Kamakari. I'm a geneticist. You said that the real time for the mutation screening is within 2 hours. What is the method that you use?
So it's a little bit proprietary in our overall methods. I could tell you that what we did is we went away from the traditional methods. So traditional methods were DNA sequencing, which is prone to error. It takes a long time to do, and it's very expensive. And so what we wanted to do, particularly when you look at the market, what drove this was to look at the refractive needs of Asia, where they do frequently same-day refractive procedures. So what we wanted to do was find the ability to be able to give the information to doctors on the same day in which they're treating the patients. So we put our clinics, our laboratories in strategic locations accessible from the clinics, where they would scooter or motorcycle the samples over to our lab, and then we could be able to turn the results around in a few hours and relay that information back to the surgery centers doing the procedure. So it's really part of our objectives, where we patented our ability to look at fast, accurate, and bringing the price down to an affordable level which can be incorporated into practice.
Are you using cellular sequencing?
No. No.
Are you using a chip, or you don't want to say?
Not, maybe you come talk to me later, but we're not advertising our methods.
Okay. And another question, please. So let me understand that, because I didn't understand it in my previous question. If a person is a mutation carrier, okay, so carries a mutation without presenting clinical symptoms, did you say that LASIK is the method that can induce clinical symptoms?
What I said is anything that creates trauma to the cornea, anything that triggers the wound healing response to the cornea will exacerbate and accelerate the advancement of these dystrophies that we're testing for.
In people who are mutation carriers in this particular gene.
Yeah, so you saw one of the opening slides that Sandra presented where the doctor did the refractive, the LASIK in one of the two eyes, and how much more and how much more quickly within 7 years that eye became a disaster. The eye that did not have the refractive, in this case LASIK procedure, was just mild symptoms. And that would be an example of what would have been natural progression for the carrier versus accelerated progression in the carrier.
Anyway, I think that an epidemiological study would be necessary, because it has been shown that the ethnic origin is very important for the mutation frequency in the world. And this also, for instance, happens for age-related macular degeneration polymorphisms, which have a very different frequency depending on the ethnic
yeah, I don't know of any such study on the TGF-beta-induced gene mutations to verify or to validate what your conclusion is there. We've progressively moved from Asia to the Western world, but there's nothing to say that the prevalence is any less or more. What we have learned is that the distribution of types of dystrophies vary within regions of the world, but there's nothing yet to say that it would be different in terms of prevalence.
Thank you.
Yes, Dr. Economo.
As you told before, that you had to try 10 times on the shot in every cheek. Why 10 times?
There's nothing magical about 10 times. It just makes it easy for me to tell you how to do it. So you could do it 20 times or you can do it 8 times. Our methods to make it simple and easy and reproducible is 10 times. We very rarely get a reject when people do it with firm pressure 10 times. We've had very good success in that way, but there's nothing magical about 10. Absolutely, thank you.
Yeah, thank you for the wonderful presentation. My name is Vasilis Yarakos. I'm actually focusing my interest in endothelial laminar surgery. So we're dealing with a lot of Fuchs endothelial dystrophy patients. And since this is also an inherited disease, autosomal dominant, we have already isolated at least 4 chromosomes carrying a gene responsible for that. Do you think, or do you hope that you might expand your lab test so that we can include also potential Fuchs endothelial dystrophy cases? Because, I mean, for example, in North Europe, it's easier to diagnose them also clinically, but in Southern Europe and in the Mediterranean, all around the Mediterranean, it's really just something that we might call good eye and might be missed somehow.
My answer to you is absolutely. That's the short answer. If you look at the brief history of our company, we've already gone from a single test to 5 tests, and it'll continue to expand. The key is that we're able to develop tests that are reliable, that are able to be useful, because there are some tests out there that we can get the knowledge, positive or negative or predisposed, but the information has limited use. So we're looking at this time in terms of how we prioritize our research. We're looking at the ability to generate good data on genes that are meaningful, that can be actionable. And so Fuchs has actionable items. So there is interest in our company in that area. I would tell you that honestly, our leading area of research is in keratoconus, but we're also very interested in glaucoma, in epithelial basement membrane dystrophy, in a number of other conditions, including Meesmann's and Fuchs and other conditions. So we're working, Gene always nicely says, the company is working from the front of the eye towards the back of the eye. And so we're in that kind of a mode as a company, but we might skip a few parts as our ability to make meaningful contributions continue to come forward.
Yeah, that would be great. We are looking forward.
Thank you. Thank you. Okay. Thank you again. Thank you.
Σας ευχαριστούμε πάρα πολύ που ήσασταν σήμερα εδώ και συμμετείχατε μαζί μας. Ευχαριστούμε πολύ για την παρουσία σας, αλλά και για τις ερωτήσεις. Είναι χαρά μας όλες αυτές οι πληροφορίες, όπως μπορείτε, με όποιον τρόπο, σιγά σιγά να γίνουν θέμα συζήτησης εκεί όπου πιστεύετε ότι υπάρχει πραγματικά ενδιαφέρον. Και πιστεύουμε ότι θα συνεχίσουμε σιγά σιγά και λίγο και στο μέλλον να πληροφορούμε περισσότερο τον κόσμο, αλλά και σίγουρα με τη βοήθεια μεγάλων ευρωπαϊκών διαθελαστικών κέντρων, όπως είναι το Αθηναϊκό Διαθελαστικό Λέιζερ, να δίνουμε λύσεις και στους ασθενείς αλλά και στους συνεργάτες αυτών των κέντρων. Ευχαριστώ πολύ. Καλό σας βράδυ. Να είστε καλά. Να είστε καλά.
Well, thank you for your answers. And we're really looking forward to actually working with Dr. Bellas and we have a lot of Fuchs and dystrophy patients. And the thing is that, you know, in North Europe, it's really easy to diagnose because it's earlier when they present symptoms. But in Southern Europe, it's really hard.
I didn't know that. I didn't know
Yeah,
that
it's
they
big
was
difference.
different. And in Northern Europe, is that more like the U.S.?
US is a little bit worse. So you can clearly see, I mean, when you compare Dutch or Finnish or Swedish with the Greek or Italian, so you can hardly see the progress there. And usually they come out only after they do facial surgery. So they come back to me as a full keratopathy and not as a Fuchs. So since you're like the best, it's easier to do it on a straightforward Fuchs than
That's the B-sector. Okay, thank you.
So it would be interesting.
This is a very